I'd like to call the February 6th Long-Term Healthcare Committee Special Committee to order. Madam Clerk, would you please call the roll?
Alderwoman Davis, Alderwoman Boyd, Alderwoman Middlebrook, Kathleen Holmes, Harold Braswell,
Present.
Lenny Jones, Marjorie Moore,
Present.
Laura Barrett,
Present.
Lavita Richardson, Victoria and Rory,
Present.
Andrew Lackey,
Present.
Annalise Stover,
Present.
Danielle Spradley, Chris Batchley. Could you pronounce it for me? Tasanya Johnson, Jamie Apsel,
Present.
Cindy Jackson, Ellen Usher,
Present.
Reverend Kevin D. Anthony,
Present.
Chair Ingracia,
Present.
Alderwoman Davis, Alderwoman Boyd, Alderwoman Middlebrook, Kathleen Holmes, Lenny Jones, Lavita Richardson, Danielle Spradley, Chris Batchley,
It's Beckley. I'm here.
Chris Beckley, okay. Tasanya Johnson, Cindy Jackson. We have 11 present. We have a quorum.
Thank you so much, Madam Chair. We're going to move to committee discussions. We do have a speaker with us today, Zach Lutz from SCIU. Are you ready to go?
Yeah, I am. If it's
Okay.
I'm up.
Great. Yes. You have 10 minutes to present, and then we'll do a Q&A. And I just have to swear you in really quickly. If you would affirm the testimony you're about to give is the whole truth and nothing but the truth.
I do.
Okay. If you could just state your name, your affiliation, your title, and then feel free to dive in. And if you need to share your screen, let us know.
Okay. All right. Well, thanks you all for having me here today. My name is Zach Lutz, and I am a senior researcher and a policy analyst with SEIU Healthcare, Illinois, Indiana, Missouri, Kansas. So I have been with the local doing policy and research work for, I guess, going on 12 years now. And yeah, it's a privilege to be here and share some of the things we've learned about the nursing home industry in that work and in our work with members. So I can introduce the organization too, for those not familiar. So SEIU Healthcare, Illinois, Indiana, Missouri, Kansas is, I believe it's the largest SEIU local in the Midwest. It's more than 90,000 home care, child care, hospital, and nursing home workers. So we have workers in kind of all areas of the care spectrum, as well as some human services stuff. And so we see long-term care, both through home care, the kind of home care lens, and the institutional care lens of nursing homes. So today I wanted to talk to you all about, some work we've done looking into critical issues that are currently sort of plaguing the nursing home industry, in the hope that, this group can be part of figuring out solutions, that our members and our union can be a part of that process too. So there's sort of 4 major trends or issues I'm going to speak to today. And all of these kind of pre-existed the pandemic, but the pandemic sort of blew the cover off of it and kind of like worsened a lot of already troubling trends in the industry. So number 1, nursing home operators too often place profitability before resident care. And in particular, a new generation of private equity-backed owners are taking this practice to like cynical new extremes. And we've seen that in St. Louis in particular over the last 2 to 3 years, dealing with some of these new owners. So that's the first issue. Second issue is that resident demographics are changing due to rebalancing. And that's kind of a process that started about 20 years ago, where folks with intellectual disabilities and folks with physical disabilities that could receive support to live in their homes, kind of exited nursing homes. So as that population exited, a lot of younger people with more severe mental illness have moved in to replace them. And the staff are ill prepared for the most part to deal with this new patient population. So that's a second issue. A third is short staffing, whether for cost control or profit maximization, and also the inability to fill open positions due to poor pay and burnout from the pandemic. And then the fourth issue is unsafe practices by the nursing home operators, including especially poor infection control, which contributed to thousands of tragic and preventable deaths during the pandemic. So I understand Laura has introduced some of these concepts to you all in the past. So hopefully I won't be redundant here, but I'm just going to go through each of these issues one by one and tease out, some of the things that we've observed and found in our research work. So first, the first issue was the introduction of private equity, or the increase of private equity ownership in nursing home industry. And in particular, it's out-of-state owners that we're seeing in Missouri and especially in St. Louis. So, whereas like most people would regard a nursing home as kind of as a part of the health and human services delivery system and care spectrum that provides care to aged, disabled persons and persons with mental illness who require round-the-clock support. But investors increasingly see nursing facilities quite differently as a low-risk, high-reward investment rather than as essential care providers, which is problematic and creates some real perverse incentives for the operators. Now, the Biden administration actually recently noted that investments in nursing homes by private equity have ballooned from $5 billion in 2000 to more than $200 billion in 2018. And I would guess if we had the next 5 years of data, we'd see a further increase because anecdotally, that's what we've observed during the pandemic. So in Missouri, private investors looking for a steal are driving a ton of churn in nursing home ownership. So roughly 1 in 6 Missouri nursing homes has changed ownership in the past 5 years. And in St. Louis City, 4 of the 17 facilities have changed hands. So, like a quarter of nursing homes in St. Louis City in the last 5 years have changed hands. And in several instances, it's been a private equity investor that's entered the market. And what we've seen when these kind of it's not universal, but too often when private equity investors get involved, quality suffers and costs go up. And actually, President Biden noted that in his State of the Union address last year. The administration has been looking to do a number of things on long-term care, but has been particularly critical of this type of ownership model. And our union has encountered this, at several facilities in St. Louis City and in the suburbs. Most notably, though, at Hillside Manor, where Luxor Healthcare, a New Jersey-based company with murky private equity backing, took over, I think a little over a year ago. And in that year, our members have reported short staffing, insufficient training, lower wages, absence of dignity and respect on the job, and then also a failure of management to abide by the collective bargaining agreement, which is outrageous. In response, we've filed a number of unfair labor practices against Luxor and also against suburban facility Blue Circle, which has, like Luxor, has kind of murky New Jersey-based private equity ownership. And we've had success taking this to the board, but there's still, that's a slow process, and we really feel additional public oversight of this type of ownership is urgently needed. So that's the first bucket. So second bucket or trend is the changing demographics. And I mentioned this earlier, a lot of this is due to rebalancing, which is a good thing that's put people in more appropriate care settings or residential settings. But it's created new challenges for nursing home operators and workers in dealing with different types of residents. And so you see this in St. Louis City, over the past 20 years, the number of residents with severe mental illness has increased dramatically to the point where almost 40% of nursing home residents in the city have a schizophrenia or bipolar disorder diagnosis. So that's a large share of the population that requires special attention. So these residents tend to be younger as well, as we've seen a lot of older folks too who can afford home care exit the nursing home space. They've increasingly been replaced by these younger residents with severe mental illness. And you can see that in Missouri, but the percentage of residents under 65 over the past 20 years increased from 16% to 39%. So that's more than doubled. And that's a really significant share of younger people who require different kind of attention. And then also we've noted that nursing homes in the city have, there's been a smaller but noticeable exodus of white residents. So the share of white residents has declined in the last 20 years by about 5%. And the residents of color has increased. So what explains these trends? The nursing home owners, in an effort to keep beds full, are moving younger people with severe mental illnesses, and many of them are also experiencing homelessness. And they're moving these folks into beds that were previously occupied by seniors and people with intellectual disabilities. And how are those trends affecting residents? Well, increasing the number of people in a facility with mental health diagnosis means that appropriate segregation of the elderly and mentally ill population is now like a constant issue. Some facilities actually now house residents with mental health issues and elderly residents together in the same room, which is in direct violation of federal guidance. And some owners are putting as many as 4 residents in a single room, which is another practice that the Biden administration flagged and condemned. On top of this, few owners have provided staff adequate training to properly support the residents with severe mental illness, which has contributed to the overuse of restraints, meaning that those residents are like literally confined to their beds, and an increase in injuries to both residents and workers. So we feel that appropriate staff training is absolutely essential to keep residents and workers safe and to better support this changing population. So the third issue is staffing. This is an issue that predates the pandemic. Nursing homes have a hard time staffing, in part because it's difficult work coupled with low pay. But the COVID pandemic really exposed and exacerbated the ongoing staffing crisis in nursing homes. So according to the Bureau of Labor Statistics, the U.S. nursing home industry shed roughly 235,000 jobs since the onset of the pandemic in March 2020, which is roughly the equivalent of 15% of the entire nursing home workforce. So that is a huge amount of churn and turnover. And then on top of that, burnout and safety concerns during the pandemic, also low pay, that's accounted for an exodus of workers from these facilities, and it's making it difficult even for good operators to adequately staff and maintain headcount. So a big issue is the pay. Certified nurse assistants in St. Louis nursing homes typically make between $14 and $16 an hour, which is comparable to or less than starting pay at major retailers like Target and Costco, as well as Amazon warehouses and many other jobs, which are equally available, but less challenging. And then uncompetitive wage. So yeah, basically uncompetitive wages paired with challenging work has made these jobs difficult to fill. And we believe strongly that we need to make these jobs good jobs in order to make them attractive to job seekers and young people looking to get into a field. And then the final issue or trend is unsafe practices. So besides worsening the staffing crisis, the COVID-19 pandemic also exposed lax safety and infection control practices in U.S. nursing homes. As a result, over 200,000 nursing home residents and staff died of COVID-19 since the onset of the pandemic, which is a huge percentage of total deaths and a totally avoidable tragedy. Since May of 2020, more than 1,100 St. Louis nursing home residents have been infected with COVID-19, and tragically, nearly 400 of them died. At the same time, 900 nursing home workers at St. Louis City nursing homes contracted COVID, and an unknown number died. Self-reported statistics, and I will just say that nursing home management is disincentivized from self-reporting due to liability issues. So I feel we don't have a great number there, but it's not the zero that's been reported. So on top of that, CMS, Centers for Medicaid and Medicare Services, who is responsible for inspecting nursing homes, they found that during the pandemic, Missouri homes were among the most reckless regarding worker and resident safety. During the past 3 years, Missouri nursing facilities reported nearly 14,000 total deficiencies, which is 8th worst amongst all states, nearly 200 serious deficiencies, which is 13th worst, and 131 infection deficiencies, which is 8th worst among states. So not a great performance in those inspections. Also, they have not, Missouri's worst in the nation for staff vaccination rates with only 74%. There's a lot of states that are at 99%. And that's not taking into account the booster. And then as far as fines goes, Missouri is, yes.
I apologize. You're a few minutes over time, but the information you're providing is important. Could you just wrap up quickly so we make sure we have time for committee members to ask questions?
Yes, I will. I can wrap up now. So yes, Missouri homes performed poorly. They paid I think the fifth most, we'll find the fifth most times, total $15.4 million, which was 10th among states. And that's not a huge number. It's not sufficient to really change employer behavior. So in conclusion, the nursing home industry desperately needs reform and additional oversight to better serve seniors and other vulnerable populations that require this type of institutional care. Nursing homes are so much more than profit centers for greedy out-of-state investors. They're essential community institutions that deserve our attention and direction. And SEIU Healthcare is excited to work with the committee to better understand the challenges facing the nursing home industry and develop solutions that put residents and workers first.
Excellent. Thank you so much for your time. I really appreciate it. And I know that you're the one who drafted pulled a lot of the data and provided a lot of the information that we have in the drive. So appreciate your work on that. At this point, I'd like to open it up to the committee members for questions. If you have a question, if you could just raise your hand and I will call on you. Go ahead, Annalise.
Hi, I'm Annalise. I'm the director of the St. Louis Area Agency on Aging. And I was just wondering, I believe that you mentioned that the fines, even though it's $15.4 million in fines, that those fines are not changing behavior. What do you think would change behavior?
I mean, I think loss of Medicare, Medicaid certification, or loss of license. Those are like the only types of penalties. And that's, I cover hospital industry too. It's like a lot of our regulatory state, the penalties don't really match the crime or whatever. So it has to be something existentially threatening, like losing a license or losing certification.
Marjorie?
Hi, Zach, I'm Marjorie from Voice. We do the long-term care ombudsman program for the city of St. Louis, as well as several other places around Missouri, and do advocacy for residents. One of the stats that you mentioned was the high number of people with schizophrenia and other diagnoses in Missouri, or specifically in the city facilities. I do want to point out, and maybe a question, that only 1% of the general population is diagnosed with schizophrenia, Huntington's, or Tourette's, which are all diseases that might warrant a antipsychotic prescription. Some of the other data that we've seen is that there are facilities out there that are misdiagnosing residents either properly or improperly with these diagnoses in order to provide them with these drugs in order to calm them down. Is this something that SEIU has seen amongst its members? So,
is Laura still on? So I'm not an organizer, so I'm not actually in the shops to talk to members like I'm also based in Kansas City, so I'm remote. But yeah, I mean, we've, anecdotally, like, and we saw this in Illinois too. Yeah, people just, I mean, even there, like the facilities would find people who, were homeless and bring them in, misdiagnose them, fill a bed, bill Medicaid. So yeah, I fully expect that percentage is inflated, and that a lot of those people are misdiagnosed. But it becomes just like another creative Medicaid fraud scheme. And it probably makes it more difficult for people with the diagnosis to get appropriate care as well.
Thank you, Harold, and then Jamie, you're next.
Hey, Zach, I'm Harold. I'm a professor. This is really helpful. Sort of naturally transitioning from Marjorie's question. So I was curious where you got the 40% number for schizophrenia and bipolar disorder, I believe, in nursing homes. Is that publicly available? I'm just kind of curious what went into that. Secondly, I guess when someone in a nursing home, this is probably a very naive question, but I would appreciate clarification. So when someone in a nursing home comes up with a schizophrenia or bipolar diagnosis, is there like a separate track within the home for them? Like, do they qualify for different services? What sort of requirements or regulations exist regarding psychiatric care, psychotherapy, other sort of basic mental health care, which, probably a lot of people in a nursing home could benefit from, but you think especially people with these very serious diagnoses?
Yeah, so the data is from, it's called Long-Term Care Focus, and it's a project by Brown University. So they have 20 years of data from 2000 to 2020, and I kind of just pulled a bunch of that data to see what the trends were and kind of let that guy, but anecdotally, we knew the population was getting younger and that there were more people who at least were getting a mental health diagnosis. So yeah, I think it's the short answer to the second question is yes, there have to be best practices, and it's an area that I haven't looked into yet extensively, but I'm going to. But it's like each resident has a care plan, and that would be tailored to their specific needs. So someone with a mental health diagnosis would have a care plan that would be based, ideally not just on medicating them, but on getting, the idea is to help people live like more independently and fuller lives, not just keep them confined to a bed. So yeah, but I think that's something, because one thing we're really interested in is getting our folks the training to deal with acute mental illness residents. And that's something we've been able to do in hospitals as well, as to get specialized training so that workers don't, often hospital workers get hurt and when they don't know how to, if someone's having a mental health episode, if they don't know the appropriate interventions. So yeah, we're going to look into what the right kind of curriculum would be for that, which requires understanding what what appropriate and humane treatment for someone with a severe mental illness is.
Zach, hi, this is Jamie Apsel. I'm curious to know, are you familiar with how other states are addressing this issues? Any gold standard policies that have been introduced to address the issues that we're discussing today?
Yeah, so Illinois is the other state I'm engaged with most. And there we have managed to reform, to push through some like payment reform that connects where the homes have to spend a percentage of their reimbursement on resident care, right? So that there's like a mandatory percentage that's going to actual residents and to worker wages too. So that's something that's been effective there, at least in terms of like increasing the amount that's spent. And that accounts for increased staffing too. So because we found there that if you just push more money at the industry, they don't actually change their practice necessarily. They may just keep the larger reimbursement and continue to understaff. So that's really what it is, I think, is more funding with stipulations. then I just think more disclosure on the ownership. Like I read there was a recent study that was by NPR and Kaiser, I believe, that was looking. So New York has really good disclosure laws for nursing home ownership, and they did an in-depth analysis of private equity presence there and its impact on care. So it's like, and that's disclosure is kind of the lowest bar, right? It allows us to make the argument for reform, if nothing else. So maybe that's something we could even get from our state government, but yeah, I think those are two things I can think of, is like creating stipulations attached to payments or participation in Medicaid, putting real penalties out there was one I mentioned earlier too, like loss of license. And then just more information, because what's tricky about the private equity owners too is they don't even appear on the LLC plans, right? The actual money doesn't. They'll have a management employee that's on them. So to a certain extent, we can't even tell who owns and operates these facilities, which are really supposed to be part of the healthcare safety net, not like a real estate investment.
Thank you.
Great. Chris and then Andrew.
Hi, Zach. My name is Chris Beckley. I'm the CEO at Cardinal Ritter Senior Services, so I'm on the provider side. I was just curious, is there any correlation with some of the stats that you shared with some of the other states on their Medicaid reimbursement versus Missouri? As you know, or may not know, on the private equity side or the for-profit side, a lot of the opportunity they have to make additional revenues to control the ancillary services, and then also some of the practices that you had mentioned as far as combining more residents in the room, which we know is not good for quality of care. But we see a pretty significant gap between the amount of reimbursement versus our cost per day. So just curious to see with some of the lower numbers in Missouri, whether some of the other states have a higher reimbursement.
Yeah, so the short answer is they definitely do. Missouri's Medicaid program is infamously stingy, and you're absolutely right. Like one of the problem for like high road operators is that who are trying to provide this critical service is that the Medicaid reimbursement rate isn't sufficient to cover the cost. So if you're a facility that has mostly low income folks in it, it's difficult, to not just to make a profit, to maintain operations, and unfortunately, like the place where some of the private equity folks are entering the market is in a lot of these high Medicaid homes, so they already have like slim or no margins. And you're absolutely right. It's like the cutting ancillary services, cutting staff, putting an unsafe number of patients in a room. And then another thing, they also siphon off money to contractors who are often, have the same principles, right? So it'll be like a property company that's a separate LLC that they're paying rent to, and then one that's a management firm with the same principles that's technically providing the operation. So that becomes like a way that that the bad operators can kind of siphon money, mostly Medicaid money, away from the home and away from providing actual resident services, but it doesn't look that way on their books. So that's another place where disclosure would be important. And I didn't mean to lump you in with the bad actors in the industry, Chris. I know, especially in the nonprofit space, there's a lot of good actors.
Thank you.
Andrew, go ahead, and then Victoria, you're up next.
Hi, Zach. I'm Andrew Lackey. I'm the Deputy Commissioner for the Office on the Disabled here in the city. And I just have a follow-up similar to what Harold was talking about with regard to the fact that you have more and more individuals with psychiatric diagnoses, and the fact that will sort of necessitate different kinds of medical care. It also means that you would need not just the certified nursing assistants, but also physicians that are licensed to give that care and and with knowledge to prescribe those kinds of medications. So have you seen data in terms of the actual MDs, or I guess DDOs, but particularly the MDs or folks with a psychiatry or psychology background that are employed in the nursing home industry, and is that sufficient, or how do those levels compare?
Well, I think that's a really good question. And I mean, I think typically, there's not a physician on site at most of these facilities. It's RNs and then like a director of nursing who are kind of responsible for day to day. But obviously, they have physician referrals, and each resident has a physician relationship. But I think, I mean, it's got to be physicians who are, making the diagnosis, right? Whether it's sincere or they're in a scheme with management to misdiagnose and bill people. But I do think that they have to be a part of a big part of the solution, particularly with this population. I think having more contact with the physician, having physicians on the premises more often would help. But I think that's a research question also, is to find out, to what extent physicians are responsible for the increase in diagnoses of these conditions.
Thanks so much. Go ahead, Victoria.
Good afternoon. I'm Victoria, Commissioner of Health for the City of St. Louis. I was just wondering, and we all know that there's a nursing shortage nationwide and also in St. Louis. Do you have any models from other states where they have been able to attract nurses to this field, and how has it made a difference with this industry in particular?
Yeah, so I mean, I will say we're struggling with this in our other states too. So I don't know that we have a silver bullet solution. I mean, we're seeing it at hospitals also, like they're relying heavily on agency staff still. It's finally only just now kind of evening out after the pandemic. But I think that we have to figure out ways to make, obviously like career ladder would be good for our folks, like who want to become a technician or, move from CNA to LPN or RN. But then also, like the pay has to be competitive. And that's an issue more at nursing homes, where you can get paid more to work retail in a lot of places with fewer headaches. But yeah, and then also I think, there's a role for like training programs as well. Like it's not an exact parallel, but like the training programs that have been developed for community health workers. Maybe something like that it doesn't upskill the job, but it's a way to bring people in and get them the appropriate training and also interest in the field. But yeah, I think it is a nationwide, statewide issue, and the shortage is real. But I think making these jobs better jobs is the best way to attract job seekers. So whatever ways, whether it's like getting the appropriate training to deal with the populations there, or getting enough compensation to get by. I think those things from our perspective can help, along with career ladder and training.
Thanks again, Zach. Does anybody have any follow-up questions? Great. Well, you are off the hook. Again, appreciate your time and all the work you've done on this today. I think this is a lot of helpful information for moving forward in the recommendations that we know we need to make. I don't think we have Ashley Mosley here. Laura, was she going to join us today?
I'm sorry, Chair.
I'm going to take that as a no. Looks like you're going to add some information in the chat or something. Just a couple of housekeeping items. I think most of you, I forgot to mention this at our meeting last week, you'll be getting emails of our meeting minutes, and I'm not going to ask us to approve the meeting minutes today. Just make sure that you have an opportunity to look those over when they get sent to you. So next week we'll approve the minutes, hopefully from the January 30th meeting and the meeting today. And then if you could look through those, a number of us committed to reaching out to individuals to have them signed up to come and speak. And so just wanted to make sure that we were following up on that pretty quickly, because we committed to having folks come in by March 13th, hopefully at the latest, so that we can have all the information we need to start drafting the report that we'll be submitting to the Board of Alderpersons. And that needs to be submitted no later than April 18th. That's the, or, excuse me, April 17th. That's the last meeting of the session. So that's all we have on the agenda for today. Does anybody have anything before we adjourn? Go ahead, Harold.
Hey, so I got confirmation from 3 people that are now on the Google Excel sheet or whatever that they are going to come. They're all academics, and I'm getting them on the schedule. I wanted to ask a question. The briefing paper that we received when we started, is that something that we could circulate to people prior to the meeting who are going to come here and speak, so that they would have a little bit more of a sense of the context of what we're talking about?
Absolutely. Yes. Thanks for asking that.
Okay.
Yeah.
Second question, and I know we don't have that much time in the schedule, but people from Places for People, the Independence Center, you know, outstanding, internationally recognized local nonprofits dealing with mentally ill people, including people who are schizophrenic or have bipolar disorder. Would it be interesting if I reached out? I know people at the Independence Center very well. I'm happy to reach out for Places for People as well. I know that they slightly different population. Would those be worthwhile people to invite to talk to us?
I think so. And somebody uploaded Nathan Dell with Places for People. I'm not sure. Yeah, if when you,
I'm
I
sorry,
guess
I didn't see that.
No worries. I don't know. People are adding things. I think they've added things very recently, and it looks like Laura Barrett reached out to him. So does that seem like, yeah, I guess that works. But yeah, the other contact information, I think that would be helpful as well. So yeah, after the list of people that we are interested in having come testify before us, I started assigning people to meeting dates. I think we can probably have 2 speakers per meeting date, unless we commit to doing more than just an hour. Sometimes if people are available, it may be that we need to go from 3 to 5 on a couple of dates. I don't know if folks have that availability. If not, I think we need to stick with 2 speakers per meeting. And so we're filling up quick. We may need to add 1 more week on March 20th and start doing some prepping of the recommendations before we hear from all the speakers. But yeah, thanks to all of you for being willing to use your expertise. Again, this is not my area of expertise, but use your experience to get the speakers before us who need to be there or need to be here. All right. I will see you all next Monday. Thanks again for everything. We are adjourned.